Ketamine is typically reserved for the most severe of chronic pain conditions like CPRS because it works on central sensitization, or the gate control theory of pain. And if you've been following along, I talk about this a lot because it really is a defining mechanism in so many chronic pain conditions. So this is how normal pain transmission works. Pain signal comes in from somewhere on your body to your spinal cord. This is a cross section of it, specifically into the dorsal horn, where it meets up with another nerve of your spinal cord and transmits that signal up to your brain. So we have the signal coming in through the first nerve. That first nerve then releases excitatory neurotransmitters like glutamate and substance P into the synaptic cleft. The second nerve soaks up all of those excitatory neurotransmitters through a receptor called the NMDA receptor. That signal can pass through and then up to your brain. But your body has checks and balances in place. So to prevent a lot of this excitatory neurotransmitter from getting through to the second nerve here in the spinal cord and to your brain, we have inhibitory interneurons that facilitate something called descending inhibition. So they release inhibitory interneurons like GABA into the synaptic cleft, which blocks a lot of that glutamate from getting through to the second nerve. This works really well in people who aren't suffering from chronic pain. But central sensitization is a hallmark of most chronic pain conditions, and it's highlighted by the fact that this inhibitory interneuron isn't doing its job anymore. So ketamine helps take the brunt of this inhibitory interneuron by just blocking this receptor. This is what a lot of pharmacology is based on, is just binding to receptors to activate them or to block them. So ketamine blocks this receptor. Glutamate, excitatory neurotransmitters can't get through. We lose all of that pain signal to the brain. Now, this mechanism works really well, but it implies that your chronic pain has to be due to an overactivation of that NMDA receptor that's constantly open, allowing more glutamate to get through, and the fact that your descending inhibition pathways also don't work. But ketamine is also a hallucinogen. So side effects can include out-of-body experiences, sedation, nausea, which doesn't exactly make it ideal for most chronic pain conditions. So instead, we have other ways to help support your biology to mimic what the ketamine is doing. First, magnesium actually helps balance all of that glutamate, but it also does block that NMDA receptor, just not as strongly as ketamine, so don't expect the exact same results. But we also need to improve this inhibitory interneuron, and that includes building up your levels of serotonin, norepinephrine, and GABA, which are all inhibitory neurotransmitters. These are all topics of previous videos, so give them a watch. Now, before we go any further, I already know that I ruffled some feathers by saying the word that shall not be said. But I want to make it clear, I am not anti-opioid. I am pro-physiology because it is important to understand how these medications work so that you know why they may or may not be working for you so that you can get the best care possible. When a nerve fires a pain signal from the first nerve to the second nerve, it releases excitatory transmitters like glutamate and substance P, which then get sucked up by the second nerve, and that signal goes on up to your brain where you feel it as pain. Now, all throughout your nervous system are opioid receptors. They're found on the presynaptic nerves, the postsynaptic nerves, and the inhibitory interneurons. So when an opioid, whether endogenous, the ones that your body makes itself, like endorphins and enkephalins, or synthetic from your prescription, those opioids bind to these receptors and block them. So now glutamate cannot go from the first nerve into the cleft or be absorbed from the cleft into the second nerve. And by binding to the opioid receptor on the inhibitory interneuron, we facilitated descending inhibition, which essentially just puts up a wall so that even if those excitatory neurotransmitters make it past the first nerve, there's a wall in the way of the second nerve. For acute pain, which these drugs were designed, the mechanism works really well. Unfortunately, opioids just weren't designed for chronic pain. So when you start to take them long term, we get this paradoxical effect called opioid-induced hyperalgesia, where the opioids that once were combating your pain are now actually making you more sensitive and contributing to your chronic pain. And there's a lot of different mechanisms by which this works, but we're only going to talk about 4 of them today. The first mechanism has to do with the NMDA receptor, which we talked about in the last video. So opioid receptors are not the only receptors found on your nerves. You also have an NMDA receptor. And when it's blocked by ketamine or magnesium, it once again prevents the absorption of excitatory neurotransmitters like glutamate and substance P into the second nerve. But opioids bind to a different part of that receptor. So instead of closing it, they actually activate it and open it so that more neurotransmitters can get through to the second nerve into your brain. The second mechanism does have to do with these opioid receptors. Under normal circumstances, they are in a GI coupled configuration, which means that they are inhibitory in nature. But with chronic opioid use, this GI configuration actually converts into a GS coupled configuration, which now makes that receptor excitatory so that you're going to feel pain to things that once didn't cause any pain. Now, the third mechanism is by the activation of microglia cells in your brain. Microglia are the primary immune cell of your brain and spinal cord, and opioids activate them, which means that they release even more inflammation. More neuroinflammation means more pain. And the fourth mechanism is that chronic opioid use actually decreases your body's production of testosterone and estrogen, which are important in their own rights for chronic pain, but specifically, estrogen is needed for the synthesis of serotonin, which is used by these inhibitory interneurons as an inhibitory neurotransmitter. So less serotonin means that there's less of this wall that gets put up blocking the pain transmission. So this is exactly why opioids probably worked well for you to begin with, but then started losing their efficacy over time, and you keep having to take more and more just to get the same effect. So how can we support your body's biology so that we can make opioids more effective, safer, or even just reduce our reliance on them? The first is by increasing production of our own endogenous opioids. And you can do so with movement and exercise, chiropractic care, acupuncture, making strong social connections, laughter, music, dance. These are all scientifically proven ways to increase endogenous opioid production. Are they going to be as strong acting and immediate as a synthetic version? No, but as a part of a greater treatment plan that addresses all the contributing factors of your chronic pain, they are really effective. Now, we can also improve NMDA receptor sensitivity with magnesium. We can improve descending inhibition by producing or helping your body produce more serotonin, norepinephrine, GABA. We can reduce neuroinflammation through nutrition and gut health, et cetera, et cetera. There are so many ways that we can help chronic pain that isn't just a reliance on synthetic drugs.